So this is actually a pretty good illustration of the effects of antidepressant treatments. Actually, you got a question?
My
yes.
question is, sometimes I see people coming in for treatment and they're on like 2 and 3 antidepressant medications at the same time. Is that indicated, or?
Well, the question was
do like one at a time.
So the question was more than sometimes this particular individual sees people on 2 or 3 antidepressants at one time. Is this indicated? What I would say to that is that it's hard to answer your question without having seen each individual cases. There are people who have chronic depression or what we call treatment-resistant depression who may not respond to one medication or even a second medication, but only respond to combinations of medications. And there are individuals out there like that. They're a smaller percentage than the people we're talking about in this particular educational panel. That's a whole different talk. Yes?
How long do you see patients usually staying on the medication? Is there a prescribed length of time?
Yeah, so we'll get to that in just a little bit, but essentially what we do is, we want to make sure that, first of all, patients' symptoms get better first. And so we will keep pushing the medication doses to the maximum therapeutic dose range. And then if that's not working, we're going to switch. We would suggest switching to another medication until we finally get to the point where the patient is getting better. And so one way to check if the patient is getting better is to look at their PHQ-9 scores. And one way that we often will tend to consider somebody doing a lot better is if the scores are halved. So if they were sort of around 20 or something like that they're around 10. And we generally are looking for scores below 10 for patients to really be, feeling a lot better. At that point, it would be reasonable to keep patients on a maintenance regimen to maintain and consolidate, all the gains that they've made and keep them on that same medication for a period of about 6 months or so. So sometimes we'll go a little bit longer, 6 to 9 months, but essentially that's what we would call a maintenance phase, keeping them on that same medication, making sure that they continue to do okay. And then at that point, it would be reasonable to start weaning them off of the medication to give them a trial off of it. Now, not everybody does well when we go through that period, as you had asked before. Sometimes we'll find that patients, as we start to decrease the dose, they don't feel good. They start feeling depressed, or they start experiencing other side effects. And at that point, it would be reasonable to, push, rather than keep them at that dose that you just reduced them to, put them back up at a higher dose.
I'll make a comment.
Sure.
So actually, the Agency for Health Care Quality and Research, which is a federal agency that does what they call quality of care research, which is kind of what we do, recommends their recommendations based on long-term epidemiological studies is that if someone has one episode of depression, it's their first episode of depression, they get treated, that they should be on an antidepressant for at least 1 year, for a full year, after their symptoms resolve, right? If they've had their second episode of depression, right, they recommend like 3 years. It's a lot longer. And from resolution, not from the time you start, but the resolution. And what they recommend if you've had 3 episodes is indefinite. So.
Nice for the drug company.
Well, I mean, I think so, but I think that it's I'm not an internist, but I think it's like any chronic illness, right? I mean, I think that if this is the one thing that helps you, it's like high blood pressure, right? I don't treat people with high blood pressure anymore, but certainly I remember if you took someone off their antihypertensive and they were running like in the 190s when they're supposed to, and actually with the medication they're running in the 130s, and then you take them off, boom.
I think that's why the treatment is so important along with it.
Yeah.
Because so many clients can also, in my experience, become emotionally addicted to the meds. And when they start to feel that it's being cut back, they start experiencing the symptoms because of some emotional tie to it.
Sure. Well, because, we all understand that, people, feel strongly tied to a lot of things, right? I mean, that would happen for any of us, right? If we got used to doing something, got out of our daily routine, we would feel a little discombobulated. But I think that by working with the patients, letting them say, okay, well, you're experiencing these symptoms. Let's go back up. We'll take it a lot slower. I mean, we can still work with them, and usually when I've had patients who have had those sort of symptoms, when we're weaning them off, usually we're able to get them off. If again, as Bowen mentioned, if this is sort of their first episode, again, it's a lot different if we're talking about people who have had multiple episodes of depression. That's a very different case. The other thing is that, in terms of those patients who need to be on, for much more extended periods of time, again, in terms of the drug companies making money, if it's $4 a month, it's not like they're making that much money off of it. I think that the main thing is that we're really looking for, are we doing right by the patient? And if this is the thing that's working for them, great. If it turns out that there's some other modality of treatment that's even cheaper, that'd be even better too. I think that the main thing is that we want the patients to ultimately, be back functioning, part of the rest of our society doing well. So, I think was this all? I think that the main thing that we just wanted to say with this slide. So going back to the slides here. The main thing that we just wanted to mention was that most of the side effects that we talked about, particularly for the SSRIs, people will experience them. Will experience them early, but they do tend to fade over time. As people, as their bodies get used to taking this medication, they start experiencing them less, with the exception of the sexual side effects. But as these side effects are going away, things start getting a lot better. If they're able to take this medication and it's working for them. So this is the reason why when we try to work with patients, we want to encourage them to stay on medication, because the most common thing I hear about from patients is, I started taking this medication and my stomach started hurting, or I experienced some diarrhea, and I decided this medication is causing problems, and I just stopped. That's not what we'd like to see, because we know this is what happens when people take their medications, that these side effects will eventually dissipate and go away over time, but they'll get better. So we really just want to try to encourage them to stay on it, to give it a try for about 6 weeks, 8 weeks or so. At some point, if they're still experiencing these symptoms after that point, if it's not getting better, maybe we need to switch. And at that point, it would be reasonable to work with the doctor or the prescriber to try something different. So again, with the sexual side effects, we did talk about this earlier. We know that for people who are depressed, again, they may be experiencing low libido, poor sexual function. So sometimes things will get better, but we do also know that these medications, particularly the SSRIs, can cause sexual dysfunction. So what we often will try to do is we'll see what will happen when we try to reduce the dose, see if the symptoms improve over that. Again, we might switch to a different medication or just even augment. And so this gets back to the question earlier about sometimes why are patients on multiple medications. And so sometimes we're doing it for a reason, and it's good to try to explore to make sure that there's a reason for it. What is probably not, what would not be okay is, if we're sort of mixing and matching medications in the same class, that's something that we, so somebody's taking Paxil and taking Prozac and taking, that doesn't make a lot of sense, because they're all doing the same thing. Sometimes, again, we'll augment with a different type of medication, Buspar or Buspirone, which is often used for anxiety. And then for patients, sometimes we will start using medications for sexual dysfunction, such as like Viagra or some of the other medications that we see ads on all the time. But if patients need treatment, we'll work with them to try to get them through it. But there are many different strategies. And so, when patients tell you that this is a problem that I'm having, it's a real problem, but there are things that a doctor can do to help them with it. I think we talked about this already in terms of the black box warning for SSRIs and the risk for suicidal behaviors. And really the big thing is close follow-up. And this goes without saying for anybody, regardless of whether or not we're worried about the black box warning for young adults. But the main thing in the collaborative care model is really making sure that there's close follow-up, that patients don't fall through the cracks. And from my side, in the doctor's office, we only see what we see coming in. And once the patient is outside, we still are concerned about the patient, but it's a little bit harder, to remember that, or to check up on the patient. It's not always easy to follow up with them, and so that's the reason why it needs to be a team approach to make sure that we know what's going on with the patient. Not only us, when they're coming to see us in other venues, but also to work with their families as well, because they're the ones who are seeing them all the time.